Now starting another important topic of neurology. So let's start it. Bismillahirrahmanirrahim. In front of you, I have represent a case scenario of 35-year-old lady who comes to neurology clinic with a double vision and diplopia and fatigue. Actually, and the fatigue gets worsened at the end of the day. On examination, the patient has a proximal myopathy, which is noticed while climbing the stairs. Okay, so the basically this double vision we have seen in the this double vision we have seen in the motor function of the motor side of the multiple sclerosis. The most important is you can see the proximal myopathy. Yes, the proximal myopathy is basically uh, a clinical presentation, or or either you can say this scenario is the clinical scenario for the myasthenia gravis. Yes, myasthenia gravis is an autoimmune disease that results from antibodies that block the nicotine acetylcholine receptors at the junction between nerves and muscles and prevent the nerve impulse from triggering the muscle contractions. Okay, so the electric impulse comes, so at acetylcholine, which is enclosed in the vesicles, they are released, attached on the ACH receptors, and there is the conduction of nerve impulse. But when antibodies when antibodies block this ACH receptors, so acetylcholine cannot bind to this, and there will be no conduction of transmission. So this is actually a myasthenia gravis condition, myasthenia gravis. Now, what it is? Associations is other autoimmune diseases like diabetes, rheumatoid arthritis, thyrotoxicosis, which is related to the thyroid gland, SLE, or thymomas causes like anti-nicotine acetylcholine receptor antibodies affect the motor and plate and neurotransmissions. Means the association can be in diabetes, rheumatoid arthritis, SLE, etc. The cause is like blockage by antibodies of the attachment area for the acetylcholine that are receptors. How the patient clinically represents clinical signs: bilateral pyrosis, very important, worsen on sustained upward gaze, complicated bilateral extraocular muscle paresis, myasthenia gravis sonar on attempting to smile, nasal speech, palatal weakness, and poor swallow, which is bulbar involvement. Okay, when this bulbar, you can see this is actually medulla oblongata. They are specifying this thing. There is a dropping of the eye. You can see it. Now, extra points demonstrate is proximal muscle weakness in the upper limbs and fragility. Reflexes are normal. Again, very important. Look for stenostomy scars. Either there any scars of it, या thymoectomy. State that you would like to assess respiratory function test. Also do the respiratory muscle function test. For diagnosis, diagnostic tests are present. Anti-ACHR antibodies are positive in 90% cases. Anti-mask, which is muscle specific kinase antibodies, also positive in this case. If anti-SH are negative, AMG discriminated response to titanic train of impulse means. Okay, so means there are gradual decrease of response to titanic train of impulse. Okay, so diagnostic tests used for like anti SCHR, which are positive in 90% cases, anti muscle specific kinase, which is positive if ACH anti ACHR is negative, in AMG, which is electromyography, that actually that shows basically a slowly gradually decrease response to titanic train of the impulses. Now, what are the treatment or test? Another test is adrophonium test, in which acetylcholine esterase inhibitor increases the concentration and ACH at the motor and end plate, and hence improve the muscle weakness more, that can cause heart block and even SSLE. So adrophonium test is also done, in which their inhibitors, the amount of inhibitors are increased, so there is increase the blockage for ACH more. CT scan MRI of the mediastinum for thymoma in 10% and TFTs, which is grave patients, in 5%. Now, treatment for acute IV immunoglobulins या plasmapheresis in chronic acetylcholine esterase inhibitors, which is actually pyridostigmine. Pyridostigmine, okay, very important, you can remember. Immunosuppressants, you can give steroids, azathioprine, thymoectomy, which is beneficial even the patient does not have thymoma, usually young females, okay. This is actually a Lambert Eaton Myasthenic syndrome, in which there are diminished reflexes that becomes brusque after exercise, lower limb gradal weakness. Unlike Myasthenia gravis associated with the malignancy, small cell lung cancer antibodies block pre-synaptic calcium channels. EMG shows a second vent phenomena on repetitive examination. Very important, second vent phenomena of repetitive stimulation.